All right, well, good morning, everybody, and thank you for waking up so early on a Monday morning to join us. We are going to talk about diagnosis and management of hip pain in the athlete. And I think most of you know, I'm Leslie Vidal. I'm one of the sports medicine orthopedic surgeons here at the Steadman Clinic. I've been here for about 3 years. At this point, my practice is about a third hip arthroscopy and management of hip pain, a third knee, and a third shoulder. So I kind of do the whole gamut of sports medicine. So let's launch things off this morning. So let's just start with a case. It's kind of a typical patient that may walk into your office or mine. This is JP. He's a 26-year-old. He's a hardcore backcountry skier, like just about everybody here is in Vail. He comes in complaining of almost a year of hip pain, left greater than right. It's located predominantly in his groin. He's tried some anti-inflammatories. He's done just a little PT and activity modification, still having quite a bit of pain. So on physical exam, he's 5'9", 155 pounds. He has a normal gait, negative Trendelenburg sign. He's got good flexibility of his lumbar spine. He's got some stiffness in his left hip relative to the right, but nothing really profound. He's got significant pain with flexion, adduction, internal rotation, as you see here, on both hips. And overall, he's got good strength and he is neurovascularly intact. We get some radiographs in the office, and this is what they look like. And I think you can see here, hopefully my mouse is going to track. He's got some extra bone. Boy, that mouse doesn't really work. Okay, he's got a little extra bone there at the femoral head-neck junction, and we'll kind of talk about the significance of that in a few minutes. So what's our differential diagnosis? Is the pain coming from his hip? Is it referred from the back? Does he have a hernia? Maybe it's a sports hernia or an inguinal hernia. Does he have the typical sort of groin pull that just won't go away? Or does he have a stress fracture? So we're going to go through kind of some of these injuries that can occur in the hip and tease out how to work on our differential diagnosis and talk about treatment options for everything. I will stop after sort of each section and give you guys a little opportunity to answer questions. And the whole talk is maybe 30 or 40 minutes, and so we'll have plenty of time at the end to answer questions. And no, to clarify, there's a button that they could push to raise their hand, or they can type in something. And would you guys see the hand raise, or okay? All right. So if you have a question you want to stop me, feel free to do so. I think there's a little button you can push that's a hand raise, and we can then unmute and we can answer questions as we go. But again, I'll stop sort of after each section if you guys have some general questions about that particular topic. So in terms of just a quick overview, of course, the hip has complex anatomy and biomechanics. Main function of the hip is to support the weight of the body in both static and dynamic situations. The hip joint, as we know, is an encapsulated synovial joint. It's basically a ball and socket in terms of its architecture. There are about 20 muscles that span the hip, and so that's where really your guys' expertise comes into play in managing a lot of the hip pain and kind of working on some of the muscular imbalance that can develop in patients with hip pain. So the acetabulum itself on the socket side is a quasi-hemisphere. It covers about half the femoral head. It's anteverted or angled forward about 15 to 20 degrees, and it's about 45 degrees angled from the orientation of the pelvis, which you can see here. On the femoral side, the angle between the neck and the shaft of the femur, I don't think my mouse is going to track quick enough, but is about 130 degrees angle, and it's also oriented forward, which we call anteversion, about 10 degrees. So it's not just sort of a flat structure, it's very three-dimensional. The labrum is a cartilaginous ring that sits around the edge of the socket, and it increases the acetabular volume by about 20% and the surface area by about 25%. Taking a closer cross-sectional look at the labrum, it's a fibrocartilaginous rim or ring. It's attached to the margin of the socket. It joins smoothly on the undersurface with the articular cartilage, joins the transverse acetabular ligament medially to truly form a ring, and it creates a fluid seal which helps protect the articular cartilage. So the bony anatomy, we've just kind of reviewed. These are all the static stabilizers of the hip, the ball and socket and the labrum. The next sort of layer is the capsule. So on the right here, you can see the joint capsule. Again, it's an encapsulated joint where there's synovial fluid inside. There are thickenings in the capsule, just like in the shoulder, that we then call the ligaments. And so the iliofemoral ligament is seen up there in the top. It's sort of an inverted Y. It's the strongest ligament in the body and really helps stabilize the hip in external rotation and extension. The pubofemoral ligament is just next to that, up again on the left, running from the pubic symphysis towards the femur. And then posteriorly in the center lower image there, you see the ischiofemoral ligament running from the ischial tuberosity towards the femur. And again, depending on the position of the hip, these bands, thickening bands in the capsule become tight in different rotation positions of the hip and provide some stability. So those are all the dynamic stabilizers, or excuse me, the static stabilizers. The dynamic stabilizers then are the muscles about the hip. So anteriorly we have the iliopsoas, which is one of the big player in terms of stabilization and potentially can be a pain generator. The pectineus, the adductor longus, the tensor fascia latus anteriorly, as is the rectus. From the posterior view, of course, we see the gluteus maximus overlying the minimus and medius. We see the adductor magnus and then the hamstrings across the hip joint posteriorly. And then laterally, we'll see the tensor fascia latus, sartorius, vastus lateralis. Again, we'll see the rectus from the lateral side, the iliotibial band, and the gluteal muscles wrap around from posteriorly to laterally. So those are all the dynamic stabilizers of the hip. Just a brief overview. We know there's the gemelles and the piriformis, etc., and a lot of the smaller muscles. Three other things to consider about the hip are the main bursa that are located about the hip. We all think of the trochanteric bursa, and people get trochanteric bursitis, but there's also a bursa just deep along the ischial tuberosity. So not all posterior hip pain is hamstring tendonitis. You can get ischial bursitis, which can be pretty uncomfortable with sitting. And then the iliopsoas has a large bursa sitting deep to the muscle tendon on top of the capsule, and so that can become inflamed as well with a tight iliopsoas and lead to iliopsoas bursitis. And so again, kind of keeping in mind all the bursa about the hip as potential pain generators as well is really important. And we're going to do a little quiz on the neurovascular anatomy at the end of the talk because it's nice and complex. I'm just kidding. So I show this slide only just to remember up top the vascular anatomy about the hip is a little precarious. And if you look to the right there's the circumflex femoral artery that goes around the femoral head. If it is injured with a fracture or with surgery or with any sort of trauma, the femoral head can lose its blood supply and develop avascular necrosis. And so that's something to keep in mind. And then the lower slide showing all the neurogenic anatomy about the hip. Of course, we're all familiar with the sciatic nerve and how it sits near the ischial tuberosity and just lateral to the hamstrings. But anteriorly, we have the femoral nerve, the lateral femoral cutaneous branch, and then the obturator nerve, which goes through the obturator foramen. With irritation and inflammation of the hip, sometimes the obturator nerve can see some irritation, and that causes referred pain down to the medial aspect of the knee. So sometimes patients with hip pathology will actually present with medial-sided knee pain, and it's important to remember that connection and always look up the chain towards the hip. Any questions on the basic bony anatomy, dynamic anatomy, neurovascular anatomy? If not, we'll move on to some specific causes of hip pain. All right, perfect. So main things we're going to cover today are femoral acetabular impingement syndrome, which I know we see a lot of around here. We're going to briefly look at stress and avulsion fractures that can occur around the hip. We're going to look at peri-trochanteric space disorders, which are injuries and inflammatory processes and degenerative processes that occur around the greater trochanter. And then we'll look at hamstring pathology because we see a lot of that as well. So FAI, or femoral acetabular impingement, occurs when there's some extra bone either on the ball side, which on the right here you can see is called a cam lesion. People can have some bony prominence sort of at the head-neck junction on the femoral side. When that hip flexes up, it literally acts like a cam and levers into the joint. If you kind of translate that over to the picture on the right, you can see how that extra bone would pinch against the labrum, leading to some impingement and potentially a labral tear. Patients can also have some excess bone on the socket side, which we call a pincer lesion. And so that extra bone can also lead to some premature bony contact and impingement and labral pathology. So if we look here, picture A, which is the upper left, is a normal hip. We're looking at it sort of from the side. If you go directly below that, that is cam type impingement, where we see the extra bone on the, I'm trying to drive with my mouse here, but it's on a delay. So we can see some extra bone here at the head-neck junction on the femoral side. So you can imagine if that hip flexed up in this forward flex direction, how it would prematurely pinch the labrum and contact the socket. So that can lead to impingement. This next image up here is C, which would be pincer type impingement, where the extra bone is on the socket side and again can lead to some impingement, pinching the labrum. And then final, the lower image is D, where most patients and the most common type is a combination type of impingement on the femur and the acetabulum. Who gets it? So the etiology can be genetic. Certainly, it's important to take a history. Anybody in your family have impingement or a hip replacement at an early age? We're seeing a lot of patients with developmental impingement. We see this in young athletes who are participating in really repetitive high-impact activities when the growth plate is still open, and so they'll develop some extra bone at that cam location, leading to cam type impingement. We see this certainly in hockey players, which has been well described, as well as in soccer players, tennis players, and dancers as well. And then patients who just undergo traumatic and repetitive microtrauma, if they have a subtle cam lesion, that can lead to pinching of the labrum over time. And then probably the vast majority of these are what we call idiopathic, meaning we don't necessarily know why they developed the impingement and the labral pathology and potential conver pathology, but they have, and so we don't necessarily have an answer. Back to the labrum for a minute. This is a little clearer picture of what it looks like. So a functional labrum slows cartilage consolidation through its hydrostatic effects. So an intact labrum has a very protective role to cartilage. So hydrostatic pressure, if you remember dropping a drop of oil between two glass slides in science class in elementary school, and those slides never touch each other because the oil is present, that's what the synovial fluid does in the joint. So the intact labrum helps maintain a nice healthy layer of synovial fluid between the cartilage on the femoral head and the cartilage on the acetabulum. If you look down the next line here, the contact stresses in acetabular cartilage increase with time, just with age, but they're up to 92% higher in the absence of the labrum. So the labrum is extremely important, and intact labrum is extremely important towards the protection of articular cartilage. So we do see patients who have a labral tear or an absence of a labrum, degenerative labrum, can go on to really pretty advanced arthritis at a young age, and so maintaining a healthy labrum is important. So the labrum typically will tear at the impingement site. So we talked before about the excess bone on either the ball side, which is the cam impingement, or the pincer side, and you can kind of see a couple of schematics here showing the impingement site. We do see a slightly different labral tear depending. So patients with cam type impingement, a cam lesion will pinch the labrum but then cause some delamination across the articular cartilage on the acetabulum, which is what we're seeing here. The probe is sort of lifting off that delamination or the peeling of the cartilage. And then somebody with more of a pincer type impingement will develop a labral tear right where the labrum meets the acetabulum. So here's the labrum here, here's the acetabulum up here, and then of course here's the labral tear in the middle. So we can kind of appreciate the types of labral pathology relative to the type of impingement. So how do we diagnose femoral acetabular impingement? Really, the vast majority of this diagnosis can be made by taking a good history. People report pain predominantly located in the groin. A lot of times people will say, boy, it hurts just sort of all around with the C sign, we call it, as this patient's showing us here. Pain can be worse with prolonged sitting or prolonged standing. It's often worse with activity, sometimes after activity, not during. People may report mechanical symptoms, a little clicking or catching in their hip. Sometimes anti-inflammatories help and sometimes they don't, so it may or may not be relieved with NSAIDs. And typically FAI pain in the hip should not radiate below the knee. As soon as it starts to radiate below the knee, we need to think of a neurogenic etiology for the pain. In terms of a physical exam, we always start with the gait and evaluating for Trendelenburg. Again, impingement in itself should not cause an abnormal gait or a Trendelenburg sign. That being said, if patients have really significant pain, they may walk with somewhat of an antalgic gait. And if they have a compensatory gait pattern from their pain, they may develop some gluteal weakness and have a subtle Trendelenburg. On the right here, the log roll test. Again, the log roll shouldn't aggravate impingement in and of itself, so it should be negative. That being said, the log roll can tell us a lot about what's going on in the hip. If patients have excessive external rotation on one or both hips, they may have some micro-instability or laxity in their joints that can predispose to impingement. And additionally, if they have limited internal rotation, they may have excessive femoral or a decreased femoral anaversion, which can also portend to a worse prognosis with impingement. So it's an important test, but in and of itself should not reproduce pain in a patient who has isolated impingement. The telltale test, obviously, is the Fader test, flexion, adduction, internal rotation, shown here on the left. So the leg is flexed up, and I kind of take it from a little bit of external rotation and then bring it across in a little bit more than 90 degrees of flexion. And before I even sort of ask the patient if they have pain, I watch their eyes. Their eyes will tell everything. So if they get a little apprehensive or close their eyes in anticipation that it's going to hurt as I bring their hip across, that's clearly a positive sign for impingement. And then the femoral abduction external rotation test is also useful if patients have a little bit more laterally based impingement, as you may see in a hockey player or hockey goalie specifically, or even a ballet dancer. They may have pain with the flexion, abduction, or external rotation or Faber test, and so that is an important test as well. Ober test can be used to test for a tight IT band, and a Stinchfield test or a straight leg raise test. We can both make sure that we don't have any radicular symptoms with the straight leg raise test, and we can check their hip flexion strength and check for iliopsoas pain with resistant straight leg raise. Once we do our history and physical exam, of course, in the office, we'll move forward with some plain radiographs. Standard radiographs are shown here. So we'll get an AP of the pelvis so we can compare both the right and the left hips. Then we do a couple of different positioning tests to look at the femoral neck and the lateral view of the hip, which we see here. That's the done lateral and the false profile. There are a lot of measurements we look at. Number one, we want to make sure if we're thinking about impingement that the patient doesn't also already have some arthritis in their hip. So we're measuring the width of the joint space between the femoral head and the acetabulum. We look at the center edge angle to see how covered the acetabulum is. Patients can have over coverage, which can be a big pincer. They can have under coverage, which is consistent with hip dysplasia. We see that in more of the female athlete population and certainly the dancers. We look at Sharp's angle, which looks at the angle of the acetabular roof. And then the alpha angle is a big player in terms of measuring how much bone we have on the femoral head neck side. That can be a way we measure for the cam lesion. The next step, if we're concerned now with our plain radiographs, our history and physical exam, that the patient may have impingement, we'll move forward with an MRI to evaluate whether they have a concomitant labral tear, which we see here on this lower image. This is what a labral tear looks like on an MRI. This structure right here is the labrum, and the fact that the white dye, in this case, goes underneath the labrum, between the labrum and the bone, shows a labral tear. Similarly, on this image up here, this is what a labral tear looks like. So in a healthy young patient, you have history, physical exam, you're concerned about impingement, x-ray shows a cam lesion. In this case, we're going to get an MRI. Here at the Steadman Clinic, as you know, we have a 3 Tesla scanner. So that's sort of like the most megapixels in the MRI scanner. So we don't need to do an arthrogram like the study I showed you before, where some dye is injected into the joint. So it saves the patient that injection at the time of their MRI. And we have a nice image here. The green arrow points to the labral tear, which you can see in the front of the hip there. So this patient is likely going to benefit from surgery. It is important, however, to remember Dr. Philippon's study he did about 10 years ago. He took 45 volunteers with no hip pain at all. Their average age was 37 years old, and found that 70% of them had a labral tear. So there's a lot of asymptomatic labral pathology. And so we have to make sure, just because a patient has a labral tear on an MRI, that it does correspond with their symptoms before considering any surgical treatment. So what are our treatment options for patients with FAI and labral pathology? Well, we always start with activity modification, stop the activity that's aggravating the symptoms. Anti-inflammatories can be helpful because there's a lot of secondary inflammation that happens from impingement. Physical therapy can be critical, and there are patients who can actually get functionally and symptomatically better from impingement with physical therapy, specifically if they have a lot of muscle imbalance and gait disturbance, and they may have certain things that are tight, certain things that have atrophied, etc. So PT can be really helpful. Injections, which we'll cover on the next slide, and of course there are surgical treatment options as well. This is a sagittal view of the hip showing what an ultrasound-guided injection looks like, and we do this very frequently in the office. The structure here is the femoral head. This is the femoral neck. Up here is the acetabulum. This little tiny structure is actually the labrum. This is the capsule on the front of the hip here, and this big kind of dark structure is the iliopsoas muscle as it crosses the hip joint. This is my needle as it's coming in to the joint and injecting kind of right along the femoral head neck junction. So in the office, we can inject the joint. We can inject the psoas tendon or bursa. We can inject the troch bursa. We may consider just a diagnostic injection, which would be a local anesthetic, which could be lidocaine. Sometimes we'll inject cortisone, again, to reduce some inflammation. And this is an area where PRP can be really valuable. Sometimes we inject bone marrow concentrate, so these are both kind of in the biologics family. And viscosupplementation, which is hyaluronic acid, Synvisc, Supards, etc., are all things that can be injected into the joint. So when do we consider moving on with surgery? Who needs a hip scope? So again, you want to make sure that their labral tear on the MRI is really the source of their pain. So they should have groin pain. They may have some secondary bursitis, tendonitis, etc. On physical exam, they definitely should have pain with impingement maneuver. Radiographically, we want to see a cam or pincer lesion. And we want to make sure they don't have severe dysplasia or any significant arthritis, because those patients really don't do well with arthroscopy. Typically, we'll make sure that they have symptoms for more than 3 months. We'll try some physical therapy and anti-inflammatories. We may or may not try a diagnostic injection. Sometimes insurance actually requires that we do an intra-articular injection that alleviates their pain at least temporarily to move forward with getting surgery approved. We need to make sure they can comply with the postoperative course. You guys all know what rehabbing a hip scope looks like, and so we want to make sure that they're going to be, able to be compliant with the routine of the crutches and the physical therapy and the return to sport. And it's also important to remember there is a size limit. So patients who carry a lot of weight, whether it's muscle or soft tissue around their hip, our scope only has a finite length. And so there are patients who just are not surgical candidates based on the amount of weight they carry around their hip. We'll just quickly move through arthroscopy because I know this is supposed to be sort of more of a focus on non-operative treatment measures, but this is quickly what arthroscopy looks like. So in the operating room, we have this x-ray on the left where we'll distract the joint. We'll use a spinal needle to get into the joint. Over that spinal needle, we'll pop the scope into the hip itself. This is what it looks like when we get in. This is the femoral head down here. This is the acetabulum or the socket, and this is what the labrum looks like. Over here, we have a very healthy labrum. We joke that when we get in with the arthroscopic fluid, the bubbles always sort of settle at the location of the labral tear. And this is what the labral tear looks like. So I've now got my metal cannula in the front. I've got a probe here. And when I push on the labrum, you can see it's not attached to the bone at all anymore, completely detached. So this patient underwent a 2-anchor repair that you can see here. These are the instruments that we use to pass the sutures. Just deep to the bruised portion of the labrum, we have a tight psoas tendon here. And in this case, I did do a limited psoas fractional lengthening. And I know you guys may have some questions about that. So as soon as we get through the FAI section here, we can talk a little bit about who's appropriate and when we consider a psoas fractional lengthening and who we should absolutely not consider that procedure on. Once we've done the intra-articular work with the labrum and any cartilage work that needs to be done, we'll release the traction so you can now see the ball is now sitting, again, well centered in the socket and that kind of air arthrogram is gone. We're now accessing the peripheral space where the cam lesion is. Schematically here, that's what this picture looks like. And when we get in with the scope, this is what a cam lesion looks like. The bone is kind of prominent. It's a little sclerotic and irregular, and it's got a bump there. So again, we can use intraoperative fluoroscopy to make sure that we're using our burr right along that cam lesion, and then we'll reshape that pathologic convexity to a physiologic concavity, which we see here. And we think we've alleviated all the bone or removed all the bone. We'll do what's called a dynamic examination, which you see on the right side here. So this hip is now flexed up, and we can take it dynamically through the impingement maneuver with the scope in the hip to make sure that there's a little space between the labrum here and the bone underneath. So you want to see a 1 or 2 millimeter gap so that there's no longer any bony impingement. When we're done with the intra-articular and the peripheral space work, we'll close the capsule, and this is what a capsular closure looks like, and we're now understanding the importance of capsular management at the time of arthroscopy and getting a good capsular repair. So this is just real quickly schematically what it looks like to do the labral repair. We've got these instruments that can pass the suture. We'll pass them through the condylabral tear site, and then usually I'll repair with a vertical mattress, which is shown here. We can pull the suture then through. This creates a nice repair at the base of the labrum, but sometimes if we loop it all the way around, it everts the labrum away from the joint, and we know one important function of the labrum is to have that nice fluid seal, and so we'll do a vertical mattress technique a lot of the time. So this is just a case example of a 15-year-old. She was a competitive lacrosse athlete. She unfortunately had under coverage, which you can see the alpha angle measure, the center edge angle measured in red there on the right, the right hip. And so because she had a really significantly undercovered head, we got an MRI. And again, that confirms the undercoverage, confirms that she's got a labral tear, which we'll see here on the right side, but healthy articular cartilage. So she underwent a combination procedure of a PAO done by Dr. Matta and arthroscopy for labral repair and a bit of an osteoplasty. So this is her hip at the time of surgery. You can see her labral tear. Labral tear is debrided. The bone is roughened. We place a couple of anchors in to repair the labrum. Again, similar technique, and we'll just move on to the next video. So when we get down in the peripheral space, she's just a little subtle cam lesion that we remove arthroscopically. Again, because she's dysplastic, we don't want to create any secondary instability, so we remove just a little bit of bone, and that's an example of the dynamic evaluation to make sure that the labrum is no longer seeing any impingement forces. So what about labral reconstruction? This has certainly gained popularity over the past 5 to 10 years. So if a patient has an irreparable labrum, a failed labral repair, or really small diminutive labrum, when we get in arthroscopically, or a really degenerative labrum, we may consider doing a labral reconstruction. In that case, most of the time we'll take some of their own IT band, which is just adjacent in the same surgical site, tubularize it, and we can perform a labral reconstruction. Post-operatively, and again, we can answer a lot of questions later if you guys have them, and I have my post-operative rehab at the end of the talk. So these are done as an outpatient in the surgery center, so I don't keep my patients overnight. I do have them wear the hip brace for about 3 weeks, limits them at flexion at 90 degrees, prevents overextension and any abduction, also controls rotation a little bit to protect the capsule. I also have them use crutches, flat foot weight bearing for 2 weeks, progress them to weight bear as tolerated between week 2 and 3, so ideally they're off the crutches altogether by week 3. I do use a CPM for passive range of motion. We encourage a stationary bike, pool therapy for some gentle active non-resisted range of motion as well. Regular PT twice a week for at least 3 to 4 months, and continuing intermittent PT with doing more on their own until a full 6 months return to full unrestricted activities. How do they do? Well, I think most of us will quote to patients, about 80% of patients get 80% better. Again, we all know that if they don't have any arthritis, if they don't have a big pincer or a big cam, if they don't have developmental hip dysplasia or concomitant pathologies, smoking and obesity and diabetes all portend to a worse prognosis. So in the absence of all of those types of risk factors, people do extremely well with arthroscopy and actually can get 95 to 100% improvement and back to sport to their previous level. Let's stop for a second. You guys have questions on femoral acetabular impingement, psoas impingement, fractional lengthening of the psoas, post-op rehab, any of those kinds of things at all? All right, Jen, I think we can hear you. Do you have a question?
You hear me?
Yeah, there you go.
Great. Do you do any work on the pincer impingement?
Yeah, absolutely. So we're a little bit, so there was a while where we were doing a lot of pincer resection, and we think we maybe over-resected a little bit. And so people would get some secondary micro instability. So absolutely, depending on the preoperative pathology, and we look at the MRI, we can get a CT scan if we really want to define the bony anatomy. Look at all those measurements on our plain radiographs. And certainly if there is a bony overhang on the socket side, we'll do a pincer resection as well.
Okay, great. Thanks.
That's the only question.
Any other questions? All right, well, we'll move on to, should I just hit the red dot and exit out of the little side box? So we'll talk about stress and avulsion fractures now. So we all know the body weight kind of travels down our spine, across the hip joints and towards the femur, towards the ground. So the femoral neck is really kind of the at-risk structure. So repetitive load can lead to femoral neck stress fractures. Stress fractures occur with abnormal load on normal bone or normal load on abnormal, which would be osteoporotic or weak bone. So you have to kind of decide in your patient population if it was just somebody who really ramped up their mileage and they're running or they're jumping and they have normal healthy bone, or if this is a patient who just sort of was doing normal day-to-day activities or their normal amount of running developed a stress fracture, they may actually have weak bone, in which case we have to address their weak bone. And so that's certainly something we see in the female athlete with the female athlete triad. So I'm frozen. Not anymore. Oops, now I'm unfrozen. Too fast. Okay, sorry guys. So there are 3 main types of femoral neck stress fractures. Top here we see compression fractures. Those are the most common. Bone heals in compression. So incomplete compression-sided or medial-sided stress fractures are inherently more stable. They typically can be treated with protected weight bearing, return to activities once they have healed, and usually don't require surgery. Next over is the tension-sided stress fractures. They occur on the lateral side of the neck. So again, every time the patient steps down, that's seeing some distraction at the fracture site. So those are inherently less stable. And even if they're incomplete, typically will require surgical stabilization. And certainly complete stress fractures and displaced stress fractures, that's when we start to worry about injury to the blood supply that we looked at to the femoral head, Displaced femoral neck fractures can be associated with avascular necrosis because of the loss of the blood supply, and so they can require emergent reduction, fixation, and eventually arthroplasty, so joint replacement if the patient develops avascular necrosis and they're not treated urgently. So this is an example of a patient who came in. She said she had difficulty walking, had to stop running completely. Telltale physical exam findings are they're unable to single leg hop. And if you have them and you sort of do that log roll and you tap their heel, if they have pain with heel tap in their groin, you should have high suspicion for a stress fracture. So oftentimes with a stress fracture, plain x-rays are totally normal. So we'll move forward with an MRI. And this is an example of a compression-sided incomplete stress fracture that was managed non-operatively. So again, you can see the fracture line is here. All the white is the bony edema, extremely painful. And then you can even see some edema and some periosteal elevation down along the femoral neck. And that's all very commonly seen with stress reactions and stress fractures. When they are treated surgically, we do a closed reduction and percutaneous pinning. So a small incision is placed. We place these screws across the fracture site. You'll see that they're threaded at the tip in the bone and they're smooth across the fracture. So as a patient, we do allow patients to partial weight bear once we put the screws across, and the bone will actually compress across the screws, really stimulating some good bone formation and healing. And they're kind of locked in on both the femoral head side and then with the heads of the screws on the trochanteric side. Protect their weight bearing, but progressive weight bearing over 6 weeks. And of course, return to sport when they heal. A lot of times patients do wind up having these screws removed because they can be a little symptomatic rubbing against the vastus lateralis and the IT band laterally. Avulsion fractures are things we should think about in our adolescent patient population. All the growth plates around the hip are interesting. They are apophyseal, not epiphyseal. So an apophysis is where the muscle tendon unit attaches to the growth plate. So it's constantly seeing traction as it's stressed. Epiphyseal growth plates are seen in our long bones. So every time you take a step, you put compression across your epiphysis. So we know bones are happy with compression, but not as happy with tension. So the apophyses with repetitive load are sort of at risk for a low-grade sort of apophysitis, which would be inflammation and irritation, or if you have some chronic apophysitis and you have a big forceful kick, you can get an actual avulsion injury of the growth plate. So again, these happen with repetitive microtrauma. Sometimes an acute traumatic event can lead to the avulsion, which we see here on the right with the arrow. Again, most of these are treated non-operatively. And we see there are multiple apophyses across the hip joint. The iliac crest fuses somewhere between 14 and 16 years old. The ASIS and the AIIS all are both apophyses. There's one at the greater trochanter. We see in soccer players and injuries to the lesser trochanter pretty frequently, and you can see those pulled off all the way from the iliopsoas insertion. And then the ischial tuberosity is an apophysis at risk as well. That's where the hamstrings attach. So this first patient is a 15-year-old ski jumper who came in, said about 2 weeks ago he had a really awkward landing and kind of landed in the back seat on his skis and felt a pop and has had a lot of pain, unable to sit since that time. He was already 2 weeks out, and on his plain x-rays, you can see this bony abnormality here across his apophysis here. We did get an MRI, and again, you can see he's got a complete avulsion of his apophysis on the right ischial tuberosity, comparing to the left where everything's completely normal. Obviously, a lot of muscle inflammation and irritation associated with that. At his 12-week x-ray, you can see everything had completely healed. So he's got this sort of extra bone over here, but complete healing of his apophysis. So again, of course, managed non-operatively. Period of rest to start with, gentle stretching, hip and core strengthening, and then a return to sport program for this athlete. Similarly, this is a 15-year-old female soccer player. So she has wide open growth plates that you can see all about her hip. Her greater troch is open, her iliac wing is open, her ASIS is open, her lesser troch is open. She complains of 2 months of left lateral hip pain. She had an acute exacerbation with a forceful soccer kick on her right. She was unable to continue to play. We got some plain x-rays. You can appreciate there's just a little bit of something funny going on with the bone here. Sorry, now I've lost my mouse altogether. On her left iliac wing. So in this case, again, we get an MRI, and you can see all of the bright signal here throughout her iliac wing on the left side. And on the sagittal view, similarly, the bone is very, very bright all the way down into the acetabular ring. And here's her actual growth plate there. That's the superior iliac spine, ASIS. And it has not yet avulsed, but she's got severe apophysitis throughout her whole iliac wing and the superior iliac spine. So again, she was managed with activity modification, rest, anti-inflammatories, ice, and then a slow return to activities. So now we'll move on to our last little section. Any questions on stress fractures or apophyseal injuries? I think particularly you guys see a lot of these adolescent athletes who may be referred to you directly from their athletic trainer at school. And if they really have pain out of proportion to their injury, or if they had an injury and they felt a pop around their hip, it's really worthwhile getting some plain x-rays and an MRI and referring them at least to get a diagnosis to see if they've got a lot of inflammation. Just gives us a little bit of direction in terms of our treatment. If they just have some tendonitis, things of course will settle down pretty quickly, but if they actually have apophysitis where there's inflammation in the bone, that's going to be a little bit more prolonged recovery, and we'll shut them down for a little bit longer before we start progressing them back to sport. So our last section, we'll talk quickly about the mature athlete, and really we talk about the 45-year-old plus athletes. We know we've got a lot of 60 and 70 and even 80-year-olds out on our mountains that really think that they're only 50, and so they come in and say, what do you mean I have arthritis? It's pretty hysterical. But in this patient population, we're going to see a lot of injuries to the gluteal tendons, so the gluteus minimus, gluteus medius. We're going to see hamstring tendon injuries, and of course in this patient population, we're going to think a little bit more about hip arthritis as opposed to hip impingement when we get up above 50 and certainly 60 and 70-year-old athletes. So the peri-trochanteric space is sort of its own separate space near to the hip, but it's totally extra-articular. So the greater trochanter, of course, is a bony structure here. We've got the insertion of the gluteus minimus and gluteus medius at the tip of the troch, the overlying trochanteric bursa, and then the gluteus maximus sort of wraps around just inferiorly to that, and then the iliotibial band is over top. So people can develop trochanteric bursitis for a number of reasons, and most often I find that it's actually related to a gait alteration that's unrelated to the hip or to the trochanteric region itself at all. So they may have had recent foot surgery or a knee injury, they may have back pain or even hip joint pain that causes them to alter their gait pattern. As soon as they have a compensatory gait, they develop weak pelvic stabilizers. They may walk with slight external rotation, their foot progression angle that can lead to a tight IT band. All of that leads to some irritation and some friction between the IT band and the tip of the troch. The bursa becomes inflamed. As soon as they develop bursitis, then they have sort of a progressively worse gait, and this can be a progressive problem. So most often we can treat this with activity modification, understanding and identifying the underlying problem, correcting that first, and then working on stretching the IT band and strengthening the hip and core muscles. Because this is an inflammatory process, either topical or oral anti-inflammatories can work. Voltaren gel, which you guys are probably pretty familiar with, used to be a prescription. It's now available over the counter, and that's a topical anti-inflammatory cream that can be helpful. And of course, the PT for IT band stretching, hip and core strengthening. The peri-trochanteric space disorders is really one place where PRP has been shown to outperform cortisone at 3 months and continuing to outperform cortisone at 2 years. So I'll consider one cortisone injection for patients, again, as a powerful local anti-inflammatory to really help them feel better so that they can participate effectively in PT. However, I don't think we're doing our patients any favors with repetitive cortisone injections into the trochanteric bursa. They certainly feel better for 2 or 3 months, but if they don't do good PT, their symptoms come right back. And over time, that cortisone can lead to some deterioration of the tendon, and those are the patients who we see these degenerative gluteal tendon tears that ultimately may require surgery. So I'll try one cortisone injection, then really encourage my patients to consider a PRP injection because we do have good data that will support that in this case. Unfortunately, PRP is still considered experimental by most insurances and is not a covered benefit, so it is an out-of-pocket cost for most patients. That being said, in rare cases, people don't get better with good PT and anti-inflammatories, and we have to move on with surgery. We can repair partial or complete gluteal tendon tears. We can perform an arthroscopic trochanteric bursectomy. We can release it or lengthen the IT band if it's chronically tight, and these are predominantly done through arthroscopic techniques or endoscopic techniques to be more accurate, but they could also be done through an open approach as well. Following a gluteal tendon repair, this is a big recovery for patients, and these tend in general to be older patients. Again, we'll protect their weight bearing in this case for 6 weeks. Crutches or walker, toe touch, flat foot, not toe touch. Hinge tip brace for even a few more weeks after they're off the crutches just to keep them slowed down. Good regular physical therapy for 3 to 4 months. Most of the time we'll return to activities by 6 months. Outcomes good for younger patients. In those rare cases we see acute tears. a little less predictable for older patients with chronic and degenerative tears. And this is an injury. There we go. Patient, she's a 65-year-old female hiker. She had a 2-year history of right lateral-sided hip pain and had a couple of injections and done some PT. However, she had a sudden increase in symptoms with worsened pain that wouldn't go away with anti-inflammatories. She had weakness. She had inability to sleep on her right side. She presented with a Trendelenburg gait, and her plain x-rays showed no arthritis in the hip joint, but she actually had this spurring at the tip of her trochanter, indicating she had sort of some traction apophysitis over time. And ultimately, she developed this huge gluteal tendon tear, which you can see on these coronal images here. That big circle of fluid is her trochanteric bursitis. But when we look over here, the bursitis is back here, and the tendon tearing is up there at the tip of the trochanter. So she did go on to surgical treatment for this problem. This is what bursitis looks like arthroscopically. That's what the tendon tear looks like. That's what the tip of the bone looks like. We place an anchor arthroscopically. We use an arthroscopic suture passer, pass our sutures, tie them down. Once the tendon is repaired, most often because the tendon is very thin in these cases, we will use a collagen patch for augmentation. And in general, if we get a good repair, people can do really well with this procedure, but it is a slow, prolonged recovery. And the rehab for this, the protocol is also at the end of the talk for you guys to review if you haven't seen it already. Let's move on to proximal hamstrings as our last little topic we'll touch on. So this is a 56-year-old female trail runner. She likes to do things like the Leadville 100. She reports an 18-month history of worsening buttock pain, worse on the right relative to the left. She says it's located right at her sits bone. It hurts to sit. She hurts after she runs and sort of towards the end of her longer runs. Occasionally she has a little radiating pain down the back of her thigh, but it never goes below the knee. She's tried a little rest and some anti-inflammatories, but really hasn't gotten much better. So in her case, we got an MRI. On exam, her strength was really good, and her main complaint was just pain. And let's get this MRI to go. So we're looking at a coronal MRI. Here's her sits bone. Here's her tendon tear here. So this will kind of scroll back through in just a second. This is her left side over here. You can see just a little bit of the tendon hanging on here and here. All the white is fluid, and she's got this high-grade partial tear with about a centimeter gap. Similar on the right side, although not quite as impressive on the MRI on the right, although her symptoms are worse on the right. So in this case, boy, this is a head scratcher. She's 56, she's super active, she's got this really impressive MRI. She still has good strength, and so we recommended a short period of activity modification to let things settle down, anti-inflammatories, physical therapy for gentle stretching, hip and core strengthening. I think with this chronic hamstring tendonitis and partial tearing, Graston scraping can be effective, dry needling can be effective, and again, alleviating symptoms. Definitely would not put any cortisone around these tendons. Cortisone could potentially, because it just sort of weakens the tissues, make this high-grade partial tear a complete tear. Then we've got a big problem on our hand. We may recommend PRP for this patient, which actually we have, after she did physical therapy, we did move forward with bilateral PRP injections. And if she continues to have symptoms, these are cases where we may consider a surgical takedown and repair. It's tricky though, we just discussed, it's a huge recovery, and would she require it bilaterally? So symptomatically she's worse on the right, but the MRI findings are worse on the left. And so at the moment she's doing well with and getting back to her long distance running routine with PRP and good physical therapy. So these are tough ones in that young 56-year-old. She's really relatively young and wants to continue her active lifestyle. Let's move on to, this is an interesting one. So this is a lady, she is, I think 78 years old, likes to do yoga up on the Continental Divide. She is a kite surfer and had a 2-year history of, this is actually her imaging of her injury. She had a 2-year history of chronic hamstring pain. She had tons of treatment modalities. Really, it bothered her all the time, but she wasn't going to let it slow her down. So she actually had felt an acute pop getting out of the water with her kite surfing. Presented to me 2 weeks out with this huge ecchymotic thigh, which you can see here, swollen, black and blue. Interestingly, she said she felt better after she felt this pop than she had in 2 years when her hamstrings ruptured. She presented with this MRI, which we'll see here. So look at the center image. All of this is fluid from her tendon tear. This is her tendon way down here. It belongs all the way up at the ischial tuberosity. So it's retracted about 6 or 7 centimeters. It's a complete tear. So in most athletes, we would say, no brainer, we've got to fix this or you're not going to regain strength and function. She said, boy, it's January. My goal is to kite surf in February. I'm feeling better already than I have in 2 years. So we managed this non-operatively. She was back to light yoga in 2 weeks, and she called me mid-February and said she's back on her kite doing kite surfing, has less pain and more strength than she had had in years. So again, you have to listen to your patient and be careful of operating on the MRI and consider a non-operative approach in certain cases like this. So to wrap it up, in terms of managing hip pain and sort of working out your differential, the location and onset of pain are critical. Pain in the groin, we're thinking of psoas tendonitis, impingement syndrome. We'll almost always start with 6 weeks of physical therapy, activity modification, anti-inflammatories, and only if they don't improve with that course, we'll consider getting an MRI. We do recommend a 3T MRI so that we can get the high quality images and not do a concomitant arthrogram study. Lateral pain is sort of this Peri-Trochanteric pain syndrome, bursitis, tendonitis, potentially a tendon tear. If the pain is insidious and they don't have any associated weakness, most often we're going to recommend anti-inflammatories and physical therapy. If they don't get better, we may consider an ultrasound-guided cortisone injection or PRP injection. If they present with gross weakness or an acute onset of pain, maybe heard a pop, we'll get an MRI sooner to evaluate the abductor tendon, because if they do have a tendon tear, we're much better off, just like the rotator cuff or anything in the body, fixing it sooner rather than later. So if they have gross weakness or heard a pop, then we'll consider an MRI sooner. And similarly, if they have an acute onset of pain, they're unable to ambulate, hear a pop, whether it's in the groin, whether it's lateral, whether it's our adolescent athlete, we may have a high suspicion of a stress fracture or avulsion fracture or more acute a tendon tear of the gluteal tendon or hamstring tendon, and we'll consider an MRI sooner. So obviously we all want to get our folks back out on the hill and on the water and on the field. So it's great that we can work together on taking care of all these patients. So think about the patient's age as you work things up. Again, apophyseal injuries aren't going to happen in our mature athletes. And of course, we always want to treat the patient and not just the imaging. So thanks so much for your time this morning, everybody. And I know a lot of you guys got to get off to clinic, but happy to stick around for a few minutes and answer some questions if you have them. All right, Jen, I think we can hear you now.
Yes.
Oh, there you go.
Speaking of the age factors, do you have a kind of a cutoff for your labral repairs?
So that's an excellent question, and that's something we just spent the last 2 days, Thursday and Friday last week, at the Vail Hip Symposium talking about arthroscopic management of hip problems. I think most of us feel like patients under 40 have the best outcomes. There is a decent number of patients between 40 and 60, and I've even gone up to 65. It's really the physiologic age of the hip and not the chronologic age of the patient that dictates things. So if the patient has absolutely no arthritis and a focal labral tear that's symptomatic, they may very well do well with an arthroscopic labral repair. We do know that tissue doesn't have the same capacity to heal once we get over 50 and certainly over 60. So we caution that they may not have great outcomes. So no, I don't have a strict age cutoff. And the oldest patient, I think actually I've done hip arthroscopy and labral repair on to 71. But in general, we start to really have that conversation, certainly after 60 and even after 55. And those patients are more likely to start showing changes on their MRI of acetabular edema or cysts or chondral thinning, those early degenerative changes. And so it's just sort of a shared decision making in a counseling conversation at that point.
Okay, great. And then what percentage, just like from a curiosity perspective, from a surgical, when you get in and do a labral repair, what percentage have either cam or pincer or combo? Almost
everybody will have either a cam or a pincer lesion. And so, that's why the labral tears, unless it's an acute traumatic tear. So probably 3 to 5% will just go in and repair the labrum. And, 95+% of the time we're resecting some bone. I'd say more often it's kind of predominantly cam based, but certainly a little bit of pincer based as well. There are kids who will have the ASIS avulsion or the AIIS avulsion, and it will heal down a little bit lower, and that leads to this concept of subspine impingement. And so we can get into the subspine space and do a pincer resection in those cases.
Okay, great. And then one other question about your stress fractures. Do you encourage any bony supplement on a stress fracture on a hip?
Great question, 100%. So any fracture, whether it's a stress fracture or a fracture off the mountain, I have a sheet that I hand out to them that talks about calcium supplementation and how much calcium your body needs when you're healing a fracture. You need 1,500 milligrams of calcium, and your body can't absorb it all at once, so you need to make sure you take some in the morning, some midday, and some in the evening. It talks about foods that are rich in calcium, and they're not all dairy-based foods, sardines, green vegetables, etc. And then it has a list of some calcium supplements. It also talks about the vitamin D that you need to take as well, and I really encourage patients to take a multivitamin and even some low-protein supplements if they're trying to heal a stress fracture. And pretty quickly off, we'll have the conversation about, particularly in our female athlete, do you have normal menses, and is this more of a female athlete triad, and do you have osteoporosis, related to your high activity level, either overexercise or undernourished, in which case we'll get them plugged in with their primary care physician or endocrinologist to do some deeper dive into their hormone balance and thyroid balance, and make sure that we're treating the whole patient and not just the stress fracture.
Right, great, thanks.
Yep. Any other questions I can answer for you guys this morning? Well,
I got one from Erica Ryan.
yep. All right, Erica, go ahead.
Okay, can you hear me?
Yes.
I just wanted to say thank you so much for taking the time to do this lecture this morning. We all appreciate it.
Absolutely. Yep. Thanks for tuning in, guys. Wish we could, be in person and see each other, but I know we're all in different locations, probably all the way from Summit to Eagle and Gypsum and everywhere in between. So thanks for taking the time this morning. And again, I will make sure that you guys have, I think Erica does, but make sure you guys all have my email and my personal cell. So if you have any questions at all, feel free to shoot me a text or shoot me an email. If you have a patient in the office and you say, boy, should I rehab him first and then send him in, or should I send him in and get some imaging and then you can send it back? Feel free to reach out to me at any point with a patient that we're managing together, or a patient you want to consider for a referral.
Sure.
All right, well, I'll hang out for just a bit more if anyone else has some questions they want to chime in with, or again, feel free to shoot me an email later if you have a question that you don't have time to ask now. And again, thanks for your attention this morning, and have a great day, everyone. Have a great week.
I got one more question from A. Doyle.
Okay, Amy, shoot. All right, Jen, I think you're up.
Oh, I don't think I have a question. But if nobody else has a question, if nobody else is on, I have I think one of your first patients you're seeing is coming from me. But I don't want to talk in front of everybody else if everyone.
Yeah, I think we still have a few people on, so.
Okay.
Yeah.
All right.
Cool. All right, guys, well, have a great day and have a great week, and hope to see you all in person at some point soon.